Thank you for joining us for the November edition of Coffee with Coker. As always, it's a privilege to have you join us. Immediately following today's presentation, we will have a question and answer period, so please feel free to submit your questions in the area provided in the GoToMeeting dashboard. The participant phone line has been muted for today's presentation, and the materials will be emailed to you shortly after the conclusion of the session. As you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation as well as suggestions for future topics. Charlie Jarvis is a senior manager at Coker's Healthcare Technology Division with 30-plus years of experience developing, implementing, and operating healthcare organizations and initiatives. He will be leading today's presentation on meeting meaningful use stages 1 through 3. Please join me in welcoming Charlie Jarvis. Charlie, I'll hand it over to you now.
Thank you very much, Savannah, and good afternoon, everybody. I hope that you'll find today's presentation both informative and thought-provoking, and hopefully you will take advantage of the question capability for you to ask us questions either now or later on after when you get slides at a little bit later date. As I think everybody knows, the long-awaited release of Meaningful Use Stage 3 with clarifications to Stages 1 and 2 is now out. And what we're going to do over the next hour is take a walk through several pieces of material that have been provided to us by CMS and that we at Coker have also put together. You'll see some slides have the CMS logo at the bottom, and that's because those are specific slides that have been provided to us by CMS, and then others we put together ourselves. Some of the slides will be a little bit detailed. I've actually gone ahead and included all the language around the various objectives for both hospitals as well as the eligible providers, so that when you get these slides from Savannah after our presentation today, you'll have them to be able to use for referencing purposes as you go back and look at them. So with that as a brief background, let's get started. I'm going to talk for about 45, maybe 50 minutes, so I can leave plenty of time for questions that might come in. It's worthwhile taking a look at the where we've been on the timeline. Many of you have probably seen this, but I think it is very helpful to kind of put things in perspective. As we all know, we started back in 2009 with the advent of the high-tech policies, and that's proceeded now up through 2016, which is really the release of improved outcomes. Now, many of you are probably somewhere in late stage 1, which is capturing data, or in early to mid stage 2, which is the use of the information exchanges. So that's where we'll concentrate. Quite honestly, when CMS released stage 3, there still is not a lot of detail around it other than the general framework, and they've actually expanded the outcomes period of time for questions so that people can still respond, and there will be another release, another more detailed release of the stage 3 information. So we're going to be as specific as we can be around 1 and 2 and give you some guidelines around stage 3 going forward. I want to keep everybody in mind that now that we've passed out of a lot of the incentives program, we really need to be concerned about penalties. And these penalties are going to grow significantly, as you can see on this particular slide. For anybody who has not attested or missed an attestation year, you are most likely getting 1% of your Medicare fee-for-service payment penalty. That grows, as you can see. So if you've been in this for 2 years, in 2015 you would be up to 2%, and 16 would remain at 2%, but then goes to 3% in 17, and we're not sure yet what's going to happen in 18. That's because the most recent, I should say the newest set of regulations that's coming out later this year, later next year, called the macro regulations, or the Medicare Access and Children's Health Information Program regulations, will be released in March or April. That is going to tie directly back into meaningful use, and it's also going to lean forward into the whole fee for outcomes program. So the penalties will most probably be increased at that time. So it really behooves your practices and your hospitals to get on board and stay on track with regard to the attestation program, because frankly, the price of poker is going to go up significantly when we get into the new macro regulations, and I can entertain some questions on that if you wish as we go forward. The other important thing to note is there still is eligibility for hardship exemptions. And if indeed you feel like you fall into one of these categories, I would urge you to follow up on this, and either we can help you with the hardship application or you can complete it yourself. But it is important to know that if you really feel like you're out on a limb and you don't have the necessary capabilities, you can still file hardship applications. And I will tell you from experience of having worked with several practices now in one hospital in terms of filing hardship applications, CMS still tends to be pretty good about that. I've not missed one yet with the clients that we've worked with. So I encourage you, if you really feel like you're in that situation, that you should go ahead and consider that piece. The major change in the regulations that was proposed, and this was not unanticipated, so everybody should be able to attest in the latter part of this year. CMS is allowing a 90-day reporting period for all participants who are looking to implement Stage 3 in 2017. That will also play back into 2015 and 16, as you'll see in a little bit. The other modifications relate to activities around patient activity, public health reporting, and some of the measurement thresholds, particularly in Stage 3, including computerized patient order entry and also electronic e-prescribing. The timeline is the following. In 2015, which is where we are now, you're going to be attesting to what are called modified criteria, and that's what we're going to go through in a little bit, for Stage 2 with qualifications or accommodations for Stage 1 providers. Nobody can attest to Stage 3 yet. The regulations aren't even finished yet. So really, the most you can do is Stage 2, Year 2. In 2016, you'll be attesting to the modified stage crew criteria. There are no accommodations for Stage 1 providers in 16. In 17, that is when the Stage 3 criteria will be out, and you will be able to attest on the Stage 3 criteria at that time. That's also the time when the macro regulations that I was just talking about earlier will be available. So they're going to tie directly into Stage 3. That's another reason why Stage 3 has not been finalized yet. And by 2018, which is going to be the first full year of penalties under the macro legislation, you'll be able to attest only to Stage 3. So everybody will need to be there by that time. Now, the reporting periods. For this year, and this year only, all providers can attest to the EHR reporting for any continuous 90-day period of time within this calendar year. You will see that you actually have, hospitals actually have a 15-month period of time because they picked up from last year, meaning 2014, and continued into 15. The big difference is that everybody has now moved to a calendar year for reporting. Hospitals who used to be on the federal fiscal year are now on the calendar year, so everybody is going to be on the same period of time. In 2016, first-time providers can still attest for the 90-day period, but everybody else must go on a full-year calendar reporting in 2016. Originally, as many of you know, if you had attested already in your Stage 1, you're already on a calendar reporting period for Stage 2 and 15. Well, that's been changed. Everybody only has to attest for 90 continuous days, any 90 continuous days, including those days that we're currently in for 2015. So that's very helpful. And you can see the criteria around 17 and 18. I won't spend a lot of time with that now. Again, you'll get these slides. But the most important thing is 15 is 90 days, 16 first-time participants are 90 days, everybody else is a full calendar year. Here are the other changes that are occurring. In Stage 1 for eligible providers, there used to be 13 core measures and 5 out of 9 menu objectives. That's been moved to all core measures now, and there's only 10 core measures. We'll go over that in a few minutes because the core measures actually have some subcategories. So in essence, it really still is really probably closer to the 13. But they have broken it down into a little simpler format, which is getting ready for stage 3, where there actually will be less objectives. And for hospitals, they have gone down to 9 objectives, including 1 consolidated health reporting with some options. And again, we'll go over that in some detail in a little bit. Changes in stage 2 go down from the 17 down to the 10. So there's 1 set of objectives. Nothing is different for anybody. The only difference is what you are attesting to within that particular stage. And again, we'll get into those details in a little bit. And likewise, with hospitals, which includes critical access hospitals, it's 9 objectives down from the original 16. The certification process, no changes in that at all. So you don't have to worry about any issues regarding your technology vendor right now. You should use technology certified to the 2014 edition of your EHR reporting, and you can move to the 2015 version when it's available, but you don't have to worry about it right now. And you really will have until well into 2017-18 until you'll have to do that. So one of the big issues that everybody faced in the past was the concern about their technology vendor being ready. CMS has tried to take that piece away, and the 2014 version should be available to you. If you don't, that's when you want to be looking at the hardship application, and we can help along those lines if you need us to. The other important point here is around the clinical quality measures. There are no changes to CQM selection or reporting schemes for the Stage 2 rule. And I think that's important for everybody to note because, as many people remember, the CQM reporting was always a bit of a bugaboo. So by reducing that piece and keeping it where things are now, you don't have to worry about changes there. And you can see on here for the EHR reporting period, it's 90 days of the CQM for the calendar year, consistent with what we just talked about before. You can also report electronically using the CQM data like you've done in the past. And in 16, you then have to go back to the attesting for 1 full calendar year of the CQM data. But for this last quarter of the year, which you're in right now, all you have to worry about is 90 continuous days, and that should be helpful to people. By the way, just as a point, and I'll get into this a little later, nobody can attest right now. The attestation website is actually not open right now. It won't be open until January 4th, and they've done that purposely because they wanted people to get a full understanding of what was going on with the criteria first before people started to jump in. Okay, we're now going to start through the objectives. And again, these next several slides are going to be a little bit technical, and I apologize for that, but I think it's important that we go through these in some detail. I'm going to cover the eligible provider slides first, and then we'll jump to the eligible hospital slides. So objective number 1 is protection of patient health information. This is the security risk analysis. And I want to emphasize that this is as important as it's ever been. This is the single biggest issue when people are audited, and we'll talk about auditing later, that people fail on. So you ought to make sure that you've got a current security risk analysis, that it is current, that you are using it and following through on it. Don't skimp on this piece. Make sure that you spend the time. I know it's detailed. I know it's tedious to get through this in some detail, but it really is important for you to do this piece and for you to have recurrent, not just for meaningful use, but with all the security breaches that we've had going around recently, it really is important for you to follow up on this component. Objective number 2, clinical decision support. And here's where we start to collapse the objectives, if you will. Here, in order to meet this particular objective, you have 2 measures under the objective to address. One is implementing 5 clinical support interventions related to 4 or more of the clinical quality measures. And absent those 4, then you must relate to high priority health conditions, which again are tied into your clinical quality measures. The other measure to be addressed here is that you can attest to the fact that you have enabled and implemented the functionality of drug-drug and drug allergy interaction checks for the entire EHR reporting period, which again for this year is only 90 days, as we've mentioned before. What is important here is in the second category, that's an attestation only. You don't have to report data on that one, but it is very, very important that if you attest positively on that point and you are audited, and we're going to get into the auditing process a little bit later on, you can prove that indeed it has been implemented, not just for one patient, but regularly. There is an alternate objective and measure for this one, and that is implementing 1 clinical decision support rule and implementing 1 measure, and the measure is implementing 1 clinical decision support rule. That only applies for people attesting in stage 1, not in stage 2. Okay, objective 3, the computerized provider order entry, the CPOE category. Again, you've got several measures that you need to address under this particular area, and there are thresholds that you have to meet here. 60% of medication orders need to be met through the period, which again, remember, is 90 days. There is an exclusion here, and it's important for you to note exclusions whenever you have them. And an eligible provider who writes fewer than 100 medication orders is excluded from this particular measure. So you do not need to worry about it if you're under 100. That sometimes applies to some specialties more than primary care. Second measure, 30% of laboratory orders. And again, the same exclusion applies, as you can see. And thirdly, 30% of radiology orders, and likewise the 100 measure, the 100 radiology order exclusion applies here as well. Now, there is an alternate measure 1 for stage 1 providers, and that is more than 30% of all unique patients with at least 1 medication list during the period of time have at least 1 medication order entered using CPOE. So you can see that you do have an alternate if you're going for stage 1. Or more than 30% of medication orders are recorded using computerized order entry. So it's you have a choice in that one. And a second alternative exclusion is people who are scheduled only to be in stage 1 in 2015 may claim an exclusion for the laboratory order component if indeed that is where they fall. So you've got some flexibility there. However, I would strive for the 60, 30, and 30 because you know that you're going to be moving towards that eventually anyway. And if you're going to be doing this, you ought to be doing it completely across the board. So while the exclusions are helpful and may get you through this year's attestation, you should be striving for the other measures if you can possibly do that. There is also a third exclusion here, and that is on radiology orders, very similar to what we just talked about for laboratory orders. Okay, moving on to objective 4, electronic prescribing. More than 50% of permissible prescriptions must be queried through the EPX system, ERX system. And I really think that in most cases people are hitting this one because ERX has been around for so long. However, there are exclusions here. If you write fewer than 100, you get out of that. If you don't have a pharmacy within your organization, or there are no pharmacies that accept electronic prescriptions within 10 miles, and oftentimes that's the case in very rural areas. And in stage 1, if you're only attesting to stage 1, it's more than 40%. So you can drop down to 40 if it's only stage 1. Stage 2 is the requirement of 50. But again, like I talked about with regard to CPOE, you really want to strive to hit the minimum of the threshold, and you really want to go much higher than that, because that's where you're going to be going forward anyway. Okay, now moving into Objective 5, the health information exchange. This one and around patient-specific education have been areas that have been a great deal of conversation in the comment lines, so it's really important for us to go over this in some detail. The requirement is that the EP transitions or refers their patients when the EP transitions their patients to another care setting. The patients you must be able to electronically transmit such data for more than 10% of transition of care referrals. Again, there is an exclusion here, and that is if you have less than 100 such transitions during the EHR reporting period, and the alternative exclusion is if you're only attesting for stage 1, all you have to do here is show that you have the capability in place. So the 10% only applies for stage 2. Now, under patient-specific education, again, patient-specific education provided for more than 10% of patients during that period of time. The exclusion is an EP who has no office visits during the EHR reporting period. So if you are a doctor that is not seeing patients in your office, then you have that exclusion. By the way, there are still excluded categories for the entire program. They fall into the areas of the emergency department, they fall into areas of laboratory, anesthesiology, and hospitalists. Now, in those cases, you still have to register your doctors, but once you register them, you can apply for an exclusion. And again, we can review that material with you if you need any help in that area. Okay, moving on to Objective 7, medication reconciliation. Again, for a while, similar to what we saw for ERX. And again, the exclusion, not dissimilar, is that if the eligible provider was not the recipient of any transitions of care during that period of time, they indeed can get out of the medication reconciliation category as well. The other qualifier here is, again, if you are only attesting to stage 1, you can claim an exclusion for this category as well. Objective 8, patient electronic access. More than 50% of all unique patients seen by the eligible provider during the reporting period are provided timely access to view, online, download, etc., etc. Now, for people that are only attesting for stage 1, you just have to be able to demonstrate that one patient has viewed, downloaded, or transmitted that information. So you do have an exclusion, or you do have a lower threshold if indeed you are only attesting to stage 1. A couple of exclusions here. If an EP neither orders or creates any information, that would be an exclusion, and conducts 50% or more of his or her encounters in a county that does not have 50% or more of its housing units. There is a qualifier there for rural health. So if you indeed think you fall into that category, again, you can get back to us and we will help you go through that process if need be. The other alternative exclusion here is providers may claim an exclusion if they are scheduled only to demonstrate in stage 1 because there was not an equivalent measure there. Objective 9, secure messaging. This is a measure for, again, this particular EHR reporting period in 2015. There is an exclusion here if any EP had no office visits during that period of time, or if they were only demonstrating in stage 1. And now Objective 10, public health reporting. An EP scheduled to be in stage 2 must meet the following 2 measures. And if you remember, immunization issues were one of those menu objectives in the past. Well, they're no longer a menu objective, but there are some qualifiers here that you'll see in a minute. Under number 1, the immunization register reporting, the EP is an active engagement with a public health agency, so you need to be able to demonstrate that. The exclusions are if they do not administer any immunizations, and there are obviously many providers that do not, operates in a jurisdiction where there's no immunization registry in place, or operates in such a area but has declared a readiness to be able to receive immunizations at the start of the EHR reporting period. So you do have some exclusions here, but if indeed you don't fall into those categories of exclusions, you need to be able to demonstrate in this particular category. The other measure here is syndromic surveillance reporting. And again, you need to be in active engagement with a public health agency. And what that means is you need to be able to demonstrate that. This is, again, an attestation area. There's not a threshold here. But again, I strongly urge that if indeed you feel that you are in, you are going to be able to attest for that positively, make sure that your records show that. And we'll get into some of that detail a little bit later. And you can see some of the exclusions here, very similar to the exclusions we had in the other category. Okay, we're now going to move to hospitals, and then we'll go to some of the areas around the actual attestation period and the area around the auditing process, which is extremely important for everybody to take note of. Okay, moving to hospitals. Specialty register report. Whoops, excuse me. Let me back up a second here. There we go, hospitals. Objective number 1, protecting patient health information, very similar, matter of fact, exactly similar to what we saw under the category of physicians. And again, hospitals, I encourage you strongly to make sure that your security risk analysis is current, is being utilized, and you're following through on it. This is an important objective to follow. There are no exemptions to this one, hence you see the word none on there. Clinical decision support, not dissimilar from what we looked at with regard to the eligible physicians. 5 clinical decision support interventions related to 4 or more clinical quality measures. Again, the clinical quality measures have not changed, so that category sits the same. Similarly, eligible hospitals have enabled and implemented the functionality of drug-drug and drug-allergy interactions. Again, you can demonstrate that, and we'll talk about that very clearly in the auditing process and how it's important to be able to document for that. The alternative, again, these alternatives get back to stage 1 implementations only. 1 clinical decision support rule relevant to high priority condition, and that's the particular measure, 1 clinical support rule. Computerized provider order entry. Again, exactly the same as what you saw for the eligible physicians. 60, 30, and 30. And again, there are some exclusions here that fall into people who are qualifying for stage 1 only. You can see them on here. Again, I'm not going to go over the wording here. It's almost identical to what you saw for the eligible providers. But again, I encourage you that if you are proceeding along these lines, you shoot to hit or exceed those thresholds. That is really the best way for you to be able to proceed in this particular area. Remember, in stage 3, I should have said this earlier, but in stage 3, all these thresholds are going to be going up to 100%. So it makes sense for you to hit as high a level as you possibly can with your thresholds right now so that you're not scrambling to do that a little bit later on. Electronic prescribing, objective number 4. Again, not dissimilar to what we saw in the other category. More than 10% of hospital discharge medications, a little bit lower threshold, but nonetheless, it's consistent in terms of the structure. Exclusions are hospitals or critical access hospitals that don't have internal pharmacies or are not located within 10 miles of such a hospital. And an alternative exclusion or a second exclusion is that you can claim this if you're only reporting for stage 1 because it was not an equivalent measure in stage 1. Objective number 5, health information exchange measure. The eligible hospital must be able to, if they refer, they must be able to demonstrate that they have electronically transmitted for more than 10% of transitions of care. And again, the alternative exclusion applies here for stage 1 as well. Objective number 6, patient-specific education. More than 10% of all unique patients are provided with patient-specific education resources identified. And again, this is one of those where you need to be able to demonstrate that because this is a data reporting that you're doing here. You can claim an exclusion for this one if you are only applying for stage 1. And you can see the criteria that's on that. Medication reconciliation. More than 50%, again, an exclusion relates if you are only applying in stage 1, as you didn't have that in the stage 1 category. Patient electronic access. More than 50% of all unique patients who are discharged of an eligible hospital or CHS are provided timely access to view online, download, transmit. Same as with the eligible providers. And again, there is an exclusion here. If you are only applying for stage 1, you only need to demonstrate that you can do it for one patient, but you do need to be able to prove that you can do that. The other exclusion here is that if you are located in a county that doesn't have the 50% housing units qualifier, again, very similar to what we looked at before when we're talking about the eligible providers. Okay, objective number 9, public health reporting. Eligible hospitals and critical access hospitals must report on 3 measures here. The immunization registry reporting, very similar to what we looked at under the eligible physicians, again, with the same exclusions on it, and the syndromic surveillance reporting, very similar, again, with the exclusions here as need be. And options 3, or measures 3 and 4, relate to specialty registry reporting. The eligible hospital is in active engagement to submit data to a specialized registry. Again, you need to be able to demonstrate that you can do that. And again, there are selected criteria for exclusion here. And then measure option 4 is the reportable laboratory reporting. And again, you need to be able to demonstrate that you can do that. And again, the exclusions are as identified here. Okay, so that's stages 1 and 2. And again, you're all going to get these slides, so you'll be getting into detail on that. Let me touch briefly on stage 3, and then I want to get into the specifics around your attestation and preparing for an audit. In stage 3, the goals have already been identified to provide clear framework around the Meaningful Use program, ensure full future sustainability of the entire incentives program, and advance the technology to improve outcomes. And outcomes is going to really be the key. And that's one of the reasons why this criteria is still pretty general, because there is going to be the macro regulations, which are going to tie directly into this on a go-forward basis. The importance here to note is that there is going to be a single stage and a single reporting period. Now, keep in mind that we talked about earlier for Stage 1 and Stage 2 reporting. Your 2015 reporting is 90 days. Your 2016 reporting is the full calendar year. When you get to Stage 3, there's going to be full calendar year reporting here. So it's important that you get used to that, because once you get on full calendar year reporting, you're going to have to continue that going forward. And the goal is to reduce paper versions of what are now electronic functions, trying to create some advanced measures to limit the duplication. As I said before, this is going to top out, which means we're going to go to 100% of those categories, such as CPOE, such as ERX. So keep in mind that's where you're going. And the objectives are going to be reduced down to 8. And it's going to be 8 for eligible providers as well as eligible physicians, as well as eligible hospitals. So the criteria is going to be a little simpler, but it's going to be much more generalized around outcomes and focus with 100% coverage. The different categories are going to be very similar to what you saw before. So while you don't have detail around the Stage 2 reporting, if you compare this against what you saw under Stages 1 and 2, you can expect that the language is going to be very, very similar, with the criteria being at 100% and the exclusions being much less. And there won't be any exclusions for prior year reporting, because everybody by 2018 is going to be reporting on Stage 3. So you can see the categories here: protecting electronic health information, electronic prescribing, clinical decision support, computerized provider order entry, the access to health information, coordination of care, health information exchange, public health reporting. So the categories are very, very similar. Now, as I said earlier at the outset of our session today, this final rule, and this is something very unique. I've never seen this before, but they have the right to do this. They can include a 60-day comment period on the Stage 3 portion of the rule. And particularly, they're seeking comments on measures, objectives, and reporting periods. Now, that comment period is open right now. So I encourage you, if you want to make some comments, you can do that. Any modifications then will come out a little bit later on. My guess is, based on the release of the other regulations that I talked about earlier, that they're probably going to release these Stage 3 regulations sometime in mid to latter part of 2016 to be able to cover that period of time. Now, that's all we have right now on Stage 3. So don't get hung up about it. Stay focused on Stages 1 and 2, because that's really important. And the balance of my time, I'm going to be talking to you about how to prepare for your 2015 submission, how to prepare for your 2016 submission, and how to prepare for an audit. So first, 2015. Most important thing you need to make sure you do is confirm the stage of your reporting. And that could vary, especially with eligible providers. You may have a practice where you've got different providers at different stages, and you have to make sure that you are putting them through at the proper stage. So that's the first thing you need to do. The other thing that's important is, if you have gained providers who were previously not with your practice, you need to make sure that you know what their previous attestation record was, because that carries with them. Attestation is provider specific. It is not practice specific. So you have got to view this on a provider by provider basis. In my opinion, I recommend this to all the clients who we directly consult with on this, that you should keep an attestation record as part of your physician's record for their credentialing. It should really be a part of your credentialing record right now. And again, I'll say it one more time because it's so important. Make sure that you have, you know what your physician's, particular physician's, attestation record is prior to coming on board with you, because that's what you are now going to be responsible for. Check the registration information, your NPPES login information, make sure the email address is correct, payment information is correct, and go into the identity and access management system to make sure that if you indeed are using surrogate users, that's up to date as well. There's a whole process that is well laid out for how people are registering, and in many cases, I would say probably in 85 to 90% of the cases, there is a surrogate reporter who's doing this. So for example, if you are in a practice of 10 doctors and you're responsible for submitting their meaningful use, you are indeed the surrogate reporter. And there's a process you need to go through with CMS to make sure you're the appropriate delegated official in the overall program. So it's important that you go through this process now and that make sure that you're in place, you have everything in place so that by the time you're ready to attest, you're not scrambling. This piece you can do now. This part of the process is open. You can go online immediately after this webinar if you want and check in on some of that information. And there is a very specific process to be able to follow. And again, we can help you if you need some guidance along these lines. CMS also has help desks that are available. And you see the names, the numbers, the websites, etc. on here. I will warn you that when you go on, many times you wind up waiting for a period of time. I've been on sometimes and waited up to an hour for getting through. So I encourage you that if you're going to go on early in the day or very late in the day, and you have a better chance of not waiting as long a period of time. And you can see that there are specific categories of information depending on what you are looking for. Remember earlier I talked about the NPPES system, the PECOS system, and the INA system. There's specific categories to go through in all of them. To attest with confidence, the important thing is register early. Like I said, you can be registering now. So you should go in and check and make sure for all the physicians in your practice that indeed you are their delegated official. You could have 10 physicians and find that 9 of them you're the delegated official, but on the 10th one you're not. So you need to go back in and make sure that you indeed are that particular delegated official. You should have one person in your practice that is overseeing compliance. I've seen many circumstances where you might have a practice and there's 4 or 5 people who are doing it. That never works. You have to have one person who's coordinating all of the information. I also encourage you strongly to run mock trials of the information so that you're actually practicing the attestation process. And do it against your scorecard. Every EHR system has a scorecard that produces data around the meaningful use attestation levels. So you should be testing just as if you were doing it yourself. Document your process. I can't say that enough. That means retaining reports, screenshots, records. Save everything you possibly can. All of the supporting information, all of your documentation. You need to be putting that in what's called a book of evidence. We're going to be talking about that in a couple minutes. But you should make copies of every single screenshot that demonstrates your compliance. Remember I showed you earlier about certain things you needed to enable. If you're testing that you're enabling something, go back and make sure that you have in your book of evidence a screenshot that shows that. So if you are possibly audited, you can be able to demonstrate that information. And again, you want to save every single piece of documentation that you possibly can. Now, I've talked so many times about the auditing process. Let me go through this in a little bit more detail. And we've got about 5 more minutes of presentation time, and then I'll be opening it up for questions, and we'll review those as we need to. CMS is auditing up to 10% of all attestations that are being submitted. It's generally pretty random, although I have seen circumstances where they've targeted specific practices where they think there may be a concern based on other matters. So if you get audited, it doesn't mean that you're being targeted other than the fact that your number came up when your name was put in the barrel. The audits are generally conducted by an outside accounting firm, the Figliosi company, and I've seen both prepayment audits and post-payment audits. So there are some circumstances where you attest, and before they pay you the money, they are checking and doing the auditing process. That's somewhat random in terms of pre versus post. Generally, I've seen it run about 75-25, most of them being post-payment audits. The auditing process is an initial letter is generally sent out electronically advising you that indeed you have been selected. The initial review process is conducted using information in the response letter, so that's often followed generally over the internet. There are some cases where I've seen on-site reviews, but in general, these are done electronically. They will secure the Figliosi company all the necessary HIPAA controls based on your security in terms of sending sensitive information. So I will remind you that you should question them if you're not seeing it coming through and refer directly back to your own risk analysis process. One of the tricks that I've seen them do is try to get through with something that's not following the process, and when someone doesn't object to it, that immediately raises a red flag in their minds. Has the particular provider followed through on their risk assessment process? So you should make sure that indeed you are practicing what you preach. Your risk assessment process needs to be used in all cases. And then the communication should go directly back to this particular organization from you. Shouldn't go to a third party at all. Documentation is absolutely the key when you are when you're going forward with this particular process. The information should be in the four different categories that I've got on here: documentation from the ONC, information around admissions, documentation of proof of completed attestations, both in the hospitals as well as the eligible providers. You should keep your documentation in both electronic and paper form. You never know when you could have an outage that might occur and not allow you to conduct an electronic review. So you should have that capability. Auditors will look for verification that the EHR system is indeed certified, so that should be all part of your book of evidence, the documentation of that. You should keep your information for a full 6 years after attestation. You can be audited. Let's say you've attested. Let's say you're at stage 2, year 2. You can still be audited for what you did in stage 1, year 1, because that's only 4 years ago. So you should make sure that you keep all of your documentation for at least a minimum of 6 years. And you have 2 weeks generally to submit your documentation once you get a request. Now, that's not a lot of time, which tells me that you want to be collecting this information now. And the guideline that I encourage all of the clients that we consult in this area is when you're collecting your documentation, when you're getting ready to do your attestation, treat it like you're getting ready for an audit. If you do it that way, then when you're audited, it's no big deal. You're just going through the process again. But that mock audit you do should be very similar to what happens in a regular audit, just simply because you're following through on the process. I've included some sample scorecards in here. They fall in many areas. So those of you that are testing the first time, you might have something in paper form. You might have something in a dashboard form, such as these speedometers that you see here, and it ties back into your screenshots. So again, these scorecards will come in various forms. They either come in, and they're all provided by the EHR provider. They either come in a documented form such as this, or something like this. There could be histograms, something along those lines. Make sure that you're pulling that information now when you're going through getting ready for your presentations, for your attestation. And keep these as part of your book of evidence as well. These are some of the sample screenshots that I'm talking about. You don't have to necessarily have the arrows on there, although it is helpful, but you want to keep screenshots like this to be able to show what you're doing when indeed you are submitting data or when you're just simply submitting for an attestation. Either way, you want to be able to demonstrate this very clearly. What's most at risk? Well, under Medicaid, the intention to adopt category and nothing's been done. If you did a test under Medicaid, you have a year and then you can skip years in between. However, you don't have more than that. So you should be making sure that indeed you're following through on that. So if you're Medicaid, there is a likelihood, maybe more than likelihood, that you'll be a part of that 10% category. You can't be close. You've got to be at your attestation levels or above. If you have an honest mistake in the attestation, the best thing to do is report it during the auditing process. The last thing you want to be doing is finding that you the auditors are finding out mistakes that you've made. That becomes very difficult because then the auditor will dig further and you could have some problems there. If you have system malfunctions during the audit, that's another problem. And don't embellish the thresholds in any way. Very quickly, I want to touch on the services that we offer, and then I'm going to get into the questions. COCR offers meaningful use assessment review. We do a review of your current meaningful use compliance. We can either do it on-site or we can do it remotely, and then we provide you with a full report. We do education, either on-site or virtually, to all staff, providers, and executives. We can help you in your audit preparation if you indeed are audited. We review your book of evidence, and we actually conduct an audit, a mock audit for you in that review process. And we can also provide meaningful use attestation support up to actually including helping you submit your attestation information. Finally, we provide security risk assessment plan development. We have a document that we're able to share with you, and we can actually implement that document for you should you request that. If you're interested in any of these, here is my contact information. Again, you will get that later on. You've also had it in the announcement that came out on this. Feel free to follow up with me even before you get the slides. So if you have any information that you wish to follow up on. Okay, we've got about a little more than 5 minutes left, so I want to go over questions that have come up here. So let's see. Is e-faxing allowed for electronically submitting prescriptions? No. E-faxing is not allowed anymore. It is only electronic transmittal. Next question. We terminated a physician. How should we handle him? I'm planning to attest the last quarter of this year. Well, if that physician is still in your practice, it is important for you to attest on his behalf. However, if he has left the practice in the terminated status, what you should do is make sure that he is made known, and I do this in documentation, that he is responsible for his own attestation. I'd send him a certified letter along those lines saying, "Dear Dr. Jones, you still need to attest on your own, and you need to make available to him all the information that he may need to attest for. He would be responsible for his own attestation, but you have to make sure you provide him that information. And if you don't, then you would be liable under those circumstances." Let's see if we have any other questions on here at all. Okay, one more question that I see coming up has to do with the auditing process, and that is I have seen a situation where we are only audited on one specific measure. How do we respond along those lines? You only respond to what you are being audited for. If indeed they're only asking for one question, then only answer that one question. The importance, however, is answering that question in a clear, concise manner with none of the hiccups that I talked about earlier. So that way, when that particular question is answered, the auditor generally is done. If you stumble around, if you don't have the right answer, if you miss your time frames, etc., that's when they can go back in and say, "Let me see some more of your information." We just recently worked with a provider that had one specific question. We helped them get that answered. The audit was done with no question at all. Another point that reminds me of is that you can ask for extensions. If indeed you feel like you need the time to be able to get your material together, I have, again, been involved with providers that have submitted for extensions, that have gotten those extensions, and the audit was still successful. I will tell you that all the audits that we've participated through so far, none of them have resulted in any money being taken back. So we think we have the knowledge of what's necessary in order to be able to follow through. Okay, let me see if there are any other questions. We still have about 2 to 3 minutes. So if anybody has any other questions, please submit them, and Savannah will get it over to me, and I'll take a look at it. Savannah, do you have any other questions that you're currently processing to get over to me?
No more questions have come in, so we'll wait just a minute more, and then just want to let everyone know the slides for this presentation will be emailed to you at the conclusion. If there are no further questions, we'll go ahead and wrap up. If you do have additional questions, you can email them directly to Charlie at the email provided. And we thank you so much for joining us today.
Thank you very much. Have a nice afternoon.